Hi, everybody. Today, we are going to learn about basal ganglia. Now, before learning the physiology of basal ganglia, I would like to give you a small case scenario at the very beginning. Right. Now, look at this case scenario. A 65-year-old male patient presented to a neurologist because he has noticed a development of a slight tremor of his left hand. The tremors involve mainly his thumb and all of his fingers. And there's another important thing noticed. Tremors are present at rest but cease or stop during voluntary movement. When he is doing some activity, these tremors are going to stop. So on examination, what has been noticed, patient performs all his movements very slowly. His face has very little expressions like a mask and increased tone in muscles. So these are the key examination findings of this patient. So based on your current knowledge of neurology, what is the possible diagnosis? Can you answer this question? All right. I think at this point, you might not be able to answer this question, but at the end of this lecture, you should be able to answer this question at least by giving the name of the disorder or the possible differential diagnosis. All right. Okay. Now let's move on to the topic today, that is basal ganglia. Now, when you talk about the basal ganglia, before basal ganglia, aside from the areas in the cerebral cortex that stimulate the muscle contraction, there are two other brain structures are very important, or if I say very essential for normal motor function. What are those? Cerebellum, and the other one is basal ganglia. They can't control muscle function by themselves alone, but they always function in association with other systems for motor control. So simply saying, actually the cerebellum and basal ganglia will aid for the function of motor coordination. So without basal ganglia and without cerebellum, you can't do or you can't execute a very proper muscular contraction. So that is the meaning of this. Now, when you look at this picture or this diagram, you can easily understand what I have told so far. Now, when you have an idea to do a certain muscular movement, that means you are thinking from your cortical association areas. And you are planning with the help of two people. Those are the things I have mentioned short while ago, that is basal ganglia and cerebellum. So these two, with the help of the cortex, cortical association areas, they will plan how this movement is going to be, the muscular movement. Suppose I'm going to flex my elbow, right hand elbow, okay? So that plan is going to be worked out through basal ganglia, cerebellum, as well as the cortex. And this idea will be given to your premotor and motor cortex. And then at the end, it will be executed with the help of cerebellum and the motor cortex. Then the movement will occur. But initially, you should remember, the idea has begun in your cortical association areas, and also it has been planned and it has been organized by your basal ganglia and the cerebellum. So by this diagram, very simply, you can understand that if you are doing a certain function or a movement of your body, definitely, other than the cortex, cerebral cortex, you need another two important key companions. Those are basal ganglia and cerebellum. So, what are these basal ganglia? Sometimes it is known as basal nuclei because these are group of deep interrelated. Those are interconnected, okay, subcortical nuclei. And this is also known as an accessory motor system that functions usually not by itself, but in close association with cerebral cortex. And remember, most of the input signals to the basal ganglia are coming from cerebral cortex, and output signals also going back to the cerebral cortex. All right. So now this slide is very important. You should remember there are mainly 5 types of basal ganglia. So what are these 5 types? Caudate, putamen, globus pallidus, substantia nigra, and subthalamic nucleus. All right. Now there are different cross sections I have put in this slide. In one cross section or in one weave, you can't see all the basal ganglia nuclei. Okay. You can only see only 1 or 2. Now, when you are looking at this one, okay, you can see caudate, you can see globus pallidus, putamen, okay, but you can't see the substantia nigra and the subthalamic nucleus. All right, but when you are looking here in this weave, you can see the substantia nigra here, and then on top of that, near to it, you can see the subthalamic nucleus, right? So in this weave, you can see putamen, globus pallidus as well. All right. And in this weave, you can see mainly the caudate nucleus, putamen, and the globus pallidus. So what are these 5 main basal ganglia? Those are caudate, putamen, globus pallidus, substantia nigra, and remember the other one, subthalamic nucleus. All right. Now, when you look at the anatomical view of the different types of basal nuclei, you can see globus pallidus, right? Now, this is the globus pallidus. It is also divided into 2 parts, external segment and internal segment. So, those 2 will secrete GABA, gamma-aminobutyric acid. That is the main neurotransmitter secreted by these 2 portions of the globus pallidus. And then when you talk about substantia nigra, again, it has 2 parts. That is pars compacta, PC. Here it is denoted by PC. And then pars reticulata. Remember, this substantia nigra is a very important component of the basal ganglia family. Because we are going to talk about a very common, not actually very common, but a common neurological disorder which is related to substantia nigra. Therefore, you should know details about substantia nigra. Now, this pars compacta portion of substantia nigra is releasing dopamine, and pars reticulata that will release GABA. Now, you have come across 2 major neurotransmitters within this basal ganglia so far. That is GABA as well as dopamine. Okay? Right. Now, I think I have shown you this type of a picture earlier as well. Now, when you're looking at this one, you can see when you closely look at this caudate and putamen is somewhat related to each other. You can see that, right? That means head of the caudate nucleus and the putamen is in close relation. Okay? And on the other hand, putamen and globus pallidus also in another view, right? You can see they are also interconnected. So because of this anatomical proximity, we have given a collective names for these 2 collections, right? For caudate and putamen together, we call as striatum because they are very closely related. And then putamen and globus pallidus also, I told you, they are also very closely packed. Therefore, these 2 combination is known as lentiform. This one is known as lentiform nucleus. There are some overlappings here, but you should know the names differently given. When you are talking only about caudate and putamen, you give striatum. And when you are talking only about putamen and globus pallidus, you give the name lentiform nucleus. All right? Right. So remember, now basal ganglia, there is a very big interconnecting circuitry through these nuclei. These circuits, I told you earlier, also start from cortex and end in the cortex. These circuits are very complex. How complex? You can realize how it is complex. it is like this, right? It's like a mess. Can you realize it? Caudate, putamen, globus pallidus, and it has so many connections with thalamus, motor cortex, premotor supplementary areas, inferior olive, subthalamic nucleus, substantia nigra. Can you see? Lots of connections. Okay. Now I have created a small, very simplified diagram, right? After taking the major points or the major sections of this basal ganglia with its connections and also the main neurotransmitters secreted to each other by these connections. All right. So if you know this much for your level at this stage, it will be enough. That means this is not the only diagram which will denote the connections of the basal ganglia. This is only a very simplified version of the connections of the basal ganglia. Remember that. Right. Now you have to actually remember this slide or this diagram by heart. Then it will be very easy to understand when you are answering questions or when you are assessing a patient. You can understand the basis of a certain disorder by using this diagram in your mind. Okay, right. Now I told you caudate and putamen is collectively known as striatum. So it's very important. Okay, so it is according to this picture, striatum is receiving input from your cortex, right? I have not specified here from what portion of the cortex. That is enough. If you, for the time being, if you know from the cortex, you will get some excitatory stimulations, right? So the neurotransmitter is glutamate to the striatum. So hereafter, if I say striatum, you should know that is the combination of caudate and putamen. Okay, right. So in between caudate and putamen, you have acetylcholine. That is actually interneuronal neurotransmitter in between these two basal nuclei. And also, this striatum will get some stimulation or some connection from reticular formation as well. But remember, the main input is from the cortex. That is why I have thickened this arrow. Now what will happen? Now, after taking all these input, right, this striatum will handle the other basal ganglia. Okay. Now, can you see it is sending some signals to globus pallidus, this striatum. So the neurotransmitter is inhibitory, that is GABA. It is always inhibitory. And also it is releasing GABA to substantia nigra as well. And look at substantia nigra. It is releasing dopamine in turn, and it will inhibit the striatum. Okay. So the globus pallidus, then of course what will do, it will secrete GABA to the thalamus, and also it will secrete GABA to the subthalamic nucleus. Okay. And from the subthalamic nucleus, you can see there's a small connection or stimulation to the glutamate, through glutamate to the globus pallidus. So there are two-way directional stimulations and inhibitions in between these nuclei as well. So as at a glance, it looks somewhat complex, but if you go through it leisurely, it will be very easy for you. And at the end, you can see substantia nigra will inhibit or will send inhibitory signals to the thalamus through GABA. But at the end, as a whole, thalamus will give its output to the cortex as an excitatory signal. That is the most important thing you have to understand. Okay? But remember, though it is excitatory thing to the cortex from the thalamus, you have to know that it is actually a combination or balance between all these interconnecting stimulations and inhibitions. So that is actually a modulated output to the cortex. Okay. So when you plan something, right, the output, right, through the basal ganglia, only it sends to the cortex is the balanced output. Though it is excitatory signal from the thalamus to the cortex, okay, it is somewhat a balanced and finalized, or that is pruned like thing, okay, prune like function or output to the cortex, right? So remember, when you're talking about these interconnections of the basal ganglia, caudate and putamen will receive input mainly. You can understand that by looking at this picture. Caudate and putamen is the main input receiver, and then globus pallidus is the major output sender. You can understand that because when you are talking about the output, you have to think from which segment of the basal ganglia it will send signals to the thalamus or to the cortex. So the main point or the main basal ganglia type which will send signals to the thalamus is globus pallidus. You can understand that. Therefore, the major output generator is globus pallidus, okay, and main input receiver is the striatum. Can you understand that? All right. So now, when you have gone through through this diagram, now you may have realized you have main two types of circuits. What are those? Main basal ganglia cortex circuits. Okay. Now we have seen that you have caudate and putamen will receive from the cortex, right? So it may be as a collection or else from the cortex to the putamen, there may be two separate small circuits. So one is known as caudate circuit, the other one is known as putamen circuit. Okay, from the cortex to the striatum differently or individually to caudate and putamen. Okay, and the other one is in between interbasal ganglia. Okay, so modulatory internal circuits between the subthalamic and the substantia nigra components of the basal ganglia family. Okay, so there are two major types. As a summary, if I say, there are two main types of circuits in the basal ganglia. Those are main basal ganglia cortex circuit. Okay, so what are those? Putamen circuit and caudate circuit. And then the second one is modulatory internal circuits. That is subthalamic nuclei between subthalamic nuclei and substantia nigra. We will see that. Now first we will look at what is this putamen circuit. It starts from premotor and supplementary areas. Now when you look at this cortical area, you can understand that here this only from very specific areas of the cortex, from your parietal cortex. So premotor and supplementary areas of the motor cortex, and also this area, that is somatosensory area of the sensory cortex. So the whole parietal cortical area, these sections, right, only they will send signals to the putamen. Okay, can you see? Putamen is receiving signals from premotor and supplementary areas as well as somatosensory area of the cortex. And they will enter to the putamen. Then to the internal, I told you, no, globus pallidus has two portions, internal and external. So then they will receive or they will send signals from the putamen to the internal portion of the globus pallidus. And then to the thalamus. Okay. From the thalamus, again, it is returning to the primary motor cortex. You can see that. So it's like a loop. It's a circuit, complete circuit. Right? So it is known as putamen circuit. Why we have identified a different type, putamen and caudate? Because the function of each circuit is different. Okay. Now, this is a basic summary of the putamen circuit, if you can remember from the cortex, but you should know the specific areas from which the putamen circuit originates. That is from the supplementary area and from your premotor cortex and your somatosensory cortex. From the cortex, those areas to the putamen, and then internal portion of the globus pallidus to the thalamus, and again to the primary motor cortex. So that is the putamen circuit. Okay, right. So what are the functions? It controls complex patterns of motor activity. Now, if you are writing alphabets of your alphabetical letters, okay, English alphabet. When you are using scissor to cut papers and hammering nails, why? These functions, they involve lot of patterns, right? Motor activity. If you are writing a letter of alphabet, so though you think it is a very simple thing at this moment, it is not so simple because you are having or you are using lot of activities, motor activities, fine motor activities with complex patterns. Okay, passing, throwing a baseball, passing a football, and also most aspects of your vocalization. Now I'm doing at this moment, okay? All these things are being controlled by your putamen circuit. It's easy to remember. Putamen, patterns of motor activity, PP, like thing, okay? And then we will move on to the next one, that is caudate circuit. This is again very important one. Now look at this picture. From where? Again, this is starting from cortex and going back to the cortex. But in between, there are some differences when you compare it with the putamen circuit. It starts from all parts of the cortex. That is the main difference. Now, when you talk about putamen circuit, it only starts from specific areas of the parietal cortex. Okay? But here, when you talk about caudate circuit, it starts from all parts of the cortex. Can you see that? Frontal cortex, parietal cortex, occipital, temporal, and lots of areas. All areas of the cortex. And then go to the caudate nucleus, and then to the globus pallidus, thalamus, and finally to the premotor cortex and sensory motor area. So that is the caudate circuit. So main difference is from which parts of the brain it starts and to which parts of the brain it will go and end. So those are the slight differences when you talk about caudate circuit and the putamen circuit. And the major difference is it is going to the caudate, previous one entering to the putamen. All right. So what is the major function? It is doing the cognitive control of the sequences of motor patterns. Okay. Now you have done patterns of motor activity. That control is going to be done by putamen circuit. But the cognitive aspect of that pattern, right, motor patterns will be governed or will be controlled by caudate circuit. Remember that. Therefore, this is very, very important. The role of caudate nucleus or the caudate circuit is very, very pivotal because it is the one which is doing the cognitive part, okay, of controlling the motor patterns. So if caudate circuit is abnormal, it is upset, then actually you can't have your putamen circuit output properly. Okay. So this is a simplified version of your caudate circuit. You can understand that, but you should know what are the differences in your cortical area. So as I told you, the major function is cognitive control of sequences of motor activity. Determine subconsciously and within seconds, within a fraction of a second, which patterns of motor movement will be used together to achieve a very complex goal that might itself last for many seconds. Okay? Right. Now we have finished putamen circuit and caudate circuit. Now we are going to do the modulatory internal circuits part. Okay, that means we are going to now learn about the internal circuits within the basal ganglia. Now, so far we have talked about the main basal ganglia, two circuits that is interconnected between the cortex and the basal ganglia. Now we will see what is happening within this basal ganglia family. Okay, so there are mainly main two components, that is subthalamic nucleus, substantia nigra, and the globus pallidus. We will see now. Can you look at this picture again? Okay, so this one, now these are the main two modulatory interbasal nuclear circuits, basal ganglia circuits. Okay, now first one is from substantia nigra to the striatum. or from striatum to the substantia nigra in both ways. I told you this is very important, substantia nigra. Can you remember? Now, when you look at this one, right, concern and mainly concern only these two portions, substantia nigra and putamen and caudate, okay, striatum. So, from the striatum to the substantia nigra, that is one way, releasing GABA, it is inhibiting substantia nigra or releasing inhibitory neurotransmitter. And then from the substantia nigra to the striatum, it is dopamine, this part, okay? So this is one intermodulatory circuit. Can you understand that? Okay. So that is actually one of the major intermodulatory circuits. So other one is, what is that? That is actually the from subthalamic nucleus to the globus pallidus or from the globus pallidus to the subthalamic nucleus. Can you realize that one as well? From the globus pallidus to the subthalamic nucleus, you are releasing GABA. Again, it is an inhibitory one, totally inhibitory. And from subthalamic nucleus to the globus pallidus, you are sending glutamate. That is excitatory. Okay, so you can add these, whether it is excitatory or inhibitory, if it is not mentioned here, right? You can do that. So this is one of the major intermodulatory connection within the basal ganglia, and from the striatum to the substantia nigra is another very important intermodulatory circuit within the basal ganglia family. And also you can see from the striatum to the globus pallidus also you are having something, but it is one way, only releasing GABA, but there is no another way from globus pallidus to the striatum. Can you understand that? That is why we have only identified two interconnections, intermodulatory pathways, because they are to the both directions, from the striatum to the substantia nigra and substantia nigra to the striatum. And the other one is intermodulatory pathway is from globus pallidus to the subthalamic nucleus, this one, and from subthalamic nucleus to the globus pallidus. So there are only two intermodulatory connections which are operating in both ways. So you should know what are the neurotransmitters involved and what are the, from which basal ganglia nucleus to the, what is the other end, like that you should know. All right. So from all these things, I told you again as well, I'm telling this one. From substantia nigra to the striatum, this dopaminergic inhibition is the most important one, because when you are learning about a certain disorder, we will discuss about it in a very few moments later. Okay? Right. So now I think so far now you have learned that some of the basal ganglia circuits, though it is main one or else intermodulatory, a small simplified ones, some are excitatory while some are inhibitory. So who is the main governor who is deciding this pathway should be excitatory and this pathway should be inhibitory? Who is? Mainly the neurotransmitter which is being secreted. Can you understand that? Okay. So inhibitory ones, most of the time GABA is always inhibitory and most of the time dopamine is inhibitory. Okay. And excitatory, usually acetylcholine, where we have seen acetylcholine in between the interneurons which are secreted between the caudate and the putamen. Okay. And others are glutamate. Glutamate also known as excitatory neurotransmitter from your cortical projections to the striatum, both to the putamen and to the caudate, as well as enkephalines are also there as a, not a major neurotransmitter, but as a neurotransmitter within these basal ganglia circuits. Right. So this one actually I told you earlier, the output from the globus pallidus to the thalamus is inhibitory, but from thalamus to the cortex is excitatory. But final outcome is, however, again, you should understand that under a balance between excitation and inhibition, It is a balanced, right? Planned and balanced output. Okay, right. So why I'm showing this diagram again and again, because it is very important to get this diagram to your mind map. Okay, so if you know this one, you can answer or you can understand any case scenario, any case presentation very well. Therefore, you should understand this one very, very carefully. Okay, so then we will see what are the functions of basal ganglia. Now you know the anatomy. Okay, to summarize, give you a small brief summary. If I tell you, there are mainly 5 types of basal ganglia. So what are basal ganglia? They are interconnected, interrelated, deep subcortical nuclei. There are mainly 5. Okay, so you should know what are those 5. And when you talk about these basal ganglia, there are mainly intermodulatory circuits as well as main basal ganglia cortex circuits. So there are 2 basal ganglia cortex circuits, that is caudate circuit as well as putamen circuit. So what is the function of caudate circuit? It will do cognition or cognitive controlling of the movements, right? Mainly the pattern of movements. So when you talk about putamen circuit, it will do the pattern, right? The controlling of the pattern of the motor movements of the body. So these 2 are like that. And then when you talk about the intermodulatory circuits within this basal ganglia family, you have 2 sets. From the subthalamic nucleus to the globus pallidus, and from globus pallidus to the subthalamic nucleus, 1. And the second one is from the substantia nigra to the striatum, and from striatum to the substantia nigra. And among all these things, I told you the main important one is from substantia nigra to the striatum, which is releasing dopamine, which will be mostly an inhibitory neurotransmitter. What is the other 100% inhibitory neurotransmitter? That is GABA. Okay, and you have glutamate. What is the circuit? Usually from the cortical projections to the striatum, you secrete glutamate. Other than that, you have acetylcholine as an excitatory neurotransmitter within these interneurons of caudate and putamen, that is between this striatum. All right, so that is the very simplified summary, right? Okay, now we will move on to the basal ganglia function. So with that thing, it's very easy to understand. Now these things are also very important. First one is it's controlling your muscle tone, okay? And then controlling voluntary movements, skilled voluntary movements, okay? You are thinking, I should do like this, and then they will do. And then basal ganglia act as a part of extrapyramidal system. That means from your corticospinal tract, or the pyramidal tract is the main tract. You know that. So extrapyramidal means other than your corticospinal or the pyramidal tract, the other parts are known as extrapyramidal system, which will control your motor activity. So basal ganglia is a part of the extrapyramidal system. Okay. So it's another function. You can take it as another function. And also remember, it stores the programs of learned patterns of motor activity. Storing function, right? And then cognitive control of motor activity. Like, who does that? Mainly the caudate. Converting your thoughts into motor actions. It initiates the subconscious automatic movement. So those are the functions of basal ganglia. Okay. Another one is, it is very important, the basal ganglia, to time and scaling of the intensity of the movements. That means it determines how rapidly the movement is to be performed and controls how large, how rapidly the movement should be and how large the movement should be done by basal ganglia. Okay. Now, when you talk about your cerebellum does the coordination. Okay. Like that, basal ganglia does the timing, scaling, okay, of the pattern recognition and all these things of the movements, how rapid and how large of the movement. So now you can understand that. If you have only your pyramidal system, it is not enough. You should have this extra pyramidal system as well to have a very properly planned movement. Can you understand that? Okay. So another function is postural adjustments for the equilibrium, right? So this postural adjustment component, basal ganglia are also doing some amount of help. Okay, not a very major one, but actually it is doing something to the postural adjustment, right? When you are talking about the balance. Right. Now, these are the functions. Now we have learned about the anatomy. Now we will move on to the basal ganglia disorders. It is very interesting as well as it is very important when you are going to your clinicals. So these are also known as extrapyramidal disorders as well. Main biochemical pathways of basal ganglia normally operate in a balanced manner. Now, so far we have learned so many circuits within the basal ganglia. No? So if you have learned and if you go leisurely through all these things, you can realize that it has distinct, very important main biochemical pathways. Okay, like from the substantia nigra to the striatum, that is a dopaminergic system. And then you know the intrastriatal, within the striatum, you know the cholinergic system, okay, acetylcholine. And from striatum to the globus pallidus and to the substantia nigra, another one is there, that is the GABA. So actually these are being recognized as in relation to the neurotransmitters, okay. So main dopaminergic systems, acetylcholine governed systems, as well as GABA related things. So it is actually a balance between all these neurotransmitters, dopamine, acetylcholine, and GABA mainly, and also glutamate from the top. So when one or more of these pathways become dysfunctional, motor abnormalities invariably will occur. Okay, because some will predominate excitatory output and some will predominate inhibitory output. So if one is out of balance, what will happen? All this coordination will be now gone. Then of course, some will govern and some will predominate and will do excitation more, some will do inhibition more. Then of course, whole balance between these basal ganglia will be in a trouble. Okay, so these diseases of basal ganglia can lead to two general types of disorders. Either they can be hyperkinetic. What is the meaning of kinetic? Something to do with your movement. Okay. So for the time being, just understand like that. So movement, if it is excessive and somewhat abnormal, which is excessive movement, we will know it, we will call it as hyperkinetic. And if the movement is very lethargic, very slow, that is known as hypokinetic. Okay. So some basal ganglia disorders, like I will tell you what are these. As an example, chorea, athetosis, balismus, they are known as hyperkinetic. So some features like akinesia, bradykinesia, those are known as hypokinetic. Okay, movements are very slow. Now lesions in the globus pallidus. Now globus pallidus is the main output generator within the basal ganglia. So that will lead, if any abnormality or a lesion occurs in the globus pallidus, it will lead to athetosis. Look at these pictures. What are athetosis? Athetosis means very spontaneous, slow, continuous breathing. Breathing means changeable. Okay, movements of hands, arm, or maybe your neck, or maybe your face. Okay, so from your picture, you can understand that there are very continuous, okay, and changeable movements of your one segment, one part of your body. That is athetosis. Then what is this? This is known as subthalamic lesion. If you have a lesion in your subthalamus nucleus, you will have hemibalismus. That is sudden flailing movements, right? Entire limb, not only hand, not only forearm, like entire limb. sudden flailing movement like this. Okay, entire limb, it is known as hemibalismus. And then putamen. These are like dancing movements. Now, when you look at these pictures, also you can understand. And now you can go through some YouTube videos if you are interested and look at what is chorea. That is actually flicking, rapid, jerky movements, hands, face, and other parts of the body. Okay. And when your hand goes like this and your neck goes like this, and then your legs move in different manners and different ways. It's a very pathetic condition, but of course, it is due to putamen. It's very pathetic and feel very sorry for patients, but you should know to identify and recognize these patients with putamen lesions. These are known as dance-like movements because different parts of your body move in different directions. So the major one is actually Huntington disease or Huntington chorea. Okay, I think you may have heard at least this word, may have seen from your textbooks. Then the most important one, right? Different stages within my lecture I have mentioned about. I have not mentioned the name, but I told you this is very important when you talk about basal ganglia. I told you substation nigra is very important. Okay, from substation nigra to striatum, you are releasing dopamine. So this is actually a lesion in that pathway, dopaminergic pathway of the substation nigra. That is Parkinson's disease. Very, very severe, but common disease, which is characterized with rigidity, very rigid, and slow akinesia or no movement, okay, akinesia or bradykinesia, and you have tremors. So these are the cardinal features. I think if you, for the time being, if you can't remember all the lesions, please at least learn and remember Parkinson's disease. That is very, very important. Okay. It is actually due to the pathology is loss of dopamine secreting neurons in the substantia nigra due to widespread destruction of the substantia nigra. This is actually a mixture of disorders, mixture of features will be there. Hypokinetic and hyperkinetic features will be there. Okay. Now, can you remember this picture, this diagram, very popular one in my lecture? Okay. Now, can you remember this pathway from substantia nigra to the striatum that is secreting dopamine? Okay. Now, if you cut that section, then of course, what will happen? Then, of course, you are having this Parkinson's disease. It can be due to drugs. Main one is idiopathic. Idiopathic means no cause, and toxins. Okay. And experimentally, you can induce Parkinson's disease using this MPTP. Okay. And this is actually, these are the characteristic clinical features, signs and symptoms of Parkinson's patient. Right. You can see the posture is different. Patient is very rigid. And face is expressionless, okay? Arms are flexed at elbows and wrists. Hips and knees are also flexed slightly and very shuffled gait, okay? And so as a mnemonic, clinical features are known as TRAP. If you remember TRAP, T means tremor, just for your interest. R means rigidity, right? Then A means akinesia, or you have to remember it as bradykinesia as well. Akinesia means no movements at all. Brady means generalized slowness of the movements. And then P means postural differences or postural difficulties. So mainly when you talk about the posture, you have stoop posture. Stoop means it is bending forward like, okay? So when you talk about tremor, tremor is a very different type of a tremor. What is it? Tremor is resting tremor. There's a difference between cerebellar tremor, you know that, right? Cerebellum also, cerebellar lesions also cause tremors. That is a different part. It is intentional tremor. When you are doing something, when you are trying to do something, when you are trying to hold a glass of water only, you get tremors if you are having a lesion of the cerebellum. But when you talk about basal ganglia, if you do nothing, that means if you are at rest, then you are having tremors. So that is why we call it as resting tremor. And these will vanish if you are trying to do something. So if you are now at rest, you are like this, but if you try to hold the glass of water, then it will stop. That is the classic picture of Parkinson's resting tremor. And what is this one? Another one, it is sometimes you call it as pill rolling tremor. Pill rolling means you are trying to roll a pin-like thing between your thumb and the index finger, like this. You are trying. Now, if you look at these patients very carefully in a very severe stage, they are trying to roll something, a rod or a like thing. You see like that. Yeah, they're trying to roll something between your index finger and the thumb. So that is why it is known as pill rolling tremor. Okay. Then why this resting tremor occurs? Because they say nobody knows what is the exact mechanism, but there are some suggested postulated mechanisms of each of these clinical features. Like now resting tremor, they say feedback circuits might easily oscillate because there are high feedback gains after loss of their inhibition. Now dopaminergic pathway is cut off now, so they will lose their inhibition. Then what will happen? High feedback gains are there within the basal ganglia. Then they might easily try to oscillate. Okay, so leads to tremor-like actions. It is actually hyperactivating movement-like thing. Then why then is bradykinesia? Bradykinesia, I told you now, this Parkinson's disease is a combination between hypokinesia and hyperkinesia. So tremors are actually hyperkinetic symptom, but bradykinesia, akinesia actually are hypokinetic symptoms. Okay, that will depend on the amount of inhibition, right? Or the which I mean, what is the amount and what is the degree of lesion? It will lead to the degree of symptoms as well. Bradykinesia are more or tremors are more will depend on the amount of damage. So bradykinesia, difficulty with daily activities such as writing, shaving, using knife and a fork to eat, right? Decrease blinking, and then all these mask-like phase also due to bradykinesia and akinesia because of slowing of your movements, right? Even to start something, it is very difficult. But remember, though you try to do something, it's very, very slow. When you start it, you can't stop it, right? It's like that. So he has to exert a very big amount of strength to start the action. But when you start it, actually you can't stop it. It is continuously going on. So what is the exact mechanism of bradykinesia? Still we don't know. But they say it is something to do with dopamine secretion in the limbic system. Okay. So along now, when you talk about the dopaminergic inhibition in the substantia nigra in this basal ganglia, if you have this disorder, there is dopamine secretion reduction in the limbic system as well as a result of this Parkinson's disease. So it will reduce the psychic drive because limbic system is something to do with your psychic drive. No, therefore, the psychic drive or to initiate this one, your cognitive power to start this motor activity will be greatly reduced. That is why you have akinesia or bradykinesia. So this is not directly related to your basal ganglia, but this is something to do with your limbic system dopaminergic secretion. Remember that. Then rigidity. What is the meaning of rigidity? Muscle tone. Rigidity is something to do with increased muscle tone, right? The whole range of movement and all muscles will be involved in rigidity. Okay, flexor, extensor compartments of your muscles, right? All these things will be involved, and whole range of movement will be involved with all the muscles. So you are having very tight, rigid movements. That is why you are having this stoop posture, flexed nature, knees, everything are flexed because of this rigidity. So when you are assessing the patient, this rigidity will manifest in two ways. Either lead pipe rigidity, and the second one is cogwheel rigidity. Lead pipe rigidity means, now I just can tell you in this lecture what are the two types. But when you are when you are assessing a patient in real situations, only you can realize what is the meaning of lead pipe rigidity and what is the meaning of cogwheel rigidity. Right? To tell you in simpler manner, lead pipe rigidity is plastic or a dead feeling like resistance of you're just bending a lead pipe. Okay, a metal known as lead, right? That is a metal now. So you are bending something like this. Okay, now you are bending something like this. Okay, that is rigidity. Throughout the movement, you are feeling the rigid nature. But if you are having a pyramidal lesion, not like this, at a certain point, if you are just extending this one very rigid, but at one point it just gives off. It just gives off. That is known as spastic type of hypertonia. Okay? That is sudden loss of resistance. You are having resistance in the initial segment, but then sudden loss. That is known as spasticity. But rigidity is not like that. Throughout your movement, you are having very difficult resistance. Remember that. Okay? And cogwheel rigidity is sometimes when you are doing this whole range of rigidity, the movement, you will feel some catches. That is not actually sudden loss of whole resistance. You will feel some catches like a cogwheel. You will feel some catches while you are doing the passive motion. That is known as cogwheel rigidity. So not all the patients with basal ganglia, this Parkinson's disease, will show cogwheel rigidity, but they will certainly have lead pipe rigidity, and in some patients, they will show cogwheel rigidity as well. So usually when you are moving your wrist, you can nicely feel this cogwheel rigidity. You are assessing using the wrist as well. Right. So how this rigidity occurs? However, again, this one, it's not very clear, the mechanism. The dopamine secreted to the caudate nucleus and putamen, you know, that is an inhibitory neurotransmitter, no? So destruction of these dopaminergic neurons in the substantia nigra would allow the caudate and putamen to become overly active. Then what will happen? Possibly cause continuous output of the excitatory signals to the corticospinal motor pathway. So these signals overly excite many or all other muscles of the body. That is why they think this is due to this over-exciting corticospinal pathway, which is leading to rigidity at the end. Okay, because of the inhibition which is being exerted from the dopamine to the striatum. I told you, no, always output from the basal ganglia, though from the thalamus to the cortex is excitatory, it is actually under a balance. Okay, but if this balance is lost, then of course this output, though it is initially excitatory, it might be over-excitatory. So it is not good. Right. So what are the other clinical features? I told you this one, mask-like face, expressionless face, then flex posture. Like that, they have very soft, rapid and indistinct speech, not very clear, and slow to start walking. And then the gait means how they walk. It is rapid, small steps. They tend to run because I told you very difficult to start, but when they try to finish it, difficult to stop. That is shuffling gait, very short steps. And arm swinging. arm swinging, when you walk, actually you just swing your arms, no? But not like that. These Parkinson's disease patients, they have reduced arm swinging because of the flexed nature and rigidity. And impaired balance, when they turn, when we ask them to turn, they lose their balance. And resting tremor, I told you that one earlier as well, about usually the frequency is 3 to 5 hertz, diminishes on action. Cogwheel rigidity, leg pipe rigidity, this is actually summary of the clinical features. Okay. And most importantly, remember, they will go into mood changes as well. Depression, right? Mild to moderate depression in 50% of the patient. It is very significant amount. 50%, half of the patients will go at one stage of the disease into depression. And cognitive impairment, because caudate, you know that, right? Caudate circuit is something to do with your cognitive thing, right? Of the movements. So slowness of execution of motor tasks, everything will be there, right? So this is actually a whole, I mean, vastly connected neurological disorder at the end. Not only movements, but also your consciousness, your cognition also can be affected, okay, with the time. So do we have treatment? Though this is actually a continuing disorder, this has no, complete cure, but somehow you can control it, right? There's a very commonly given drug that is known as levodopa or L-dopa. That is primary treatment for Parkinson's disease. It is a dopamine precursor. Why we use this L-dopa? Because it crosses the blood-brain barrier. If you give dopamine, okay, directly it will not process, it will not cross your blood-brain barrier, so not effective. Therefore, you will give dopamine precursor, L-dopa, which is blood-brain barrier crossing. That is the main thing, the significant feature of L-dopa. Then it will go and convert into dopamine and then exert the dopamine inhibition on the basal ganglia. So this is initially effective, but after about 5 to 10 years or so, 50% of patients will develop L-dopa induced dyskinesia. That means this drug also, if it is a long-term used one, it will also cause some movements. So, but it is long-term. Okay. And then you can use, not then actually, by this time, you can go into some other drugs as well. So now you can, if you are interested, you can find out other than L-dopa or levodopa, what are the other treatment options which are available for Parkinson's disease. Because now still we are, in this lecture, we are only talking about basic physiology of basal ganglia. No? So we have just to go far beyond that thing to talk about Parkinson's disease as well as to treatment options as well. But if you are interested, I think if you can find out what are the other treatment options available for Parkinson's disease. This is the primary and most simple treatment option. And very important when you are going for your exams as well, you should know what is the basis of levodopa or L-dopa and what are the basis of clinical features of Parkinson's disease as well. All right. So till we meet from another lecture, goodbye for all of you. Okay. Right.